So renal and urinary. So first of all, I apologize because your book does not have a very good section on this. It has a section on electrolytes, which is sort of interesting and sort of germane, but not particularly. And urinary, it has very little. So mostly you're going to have to find some references on the internet, watch the other videos that I post. It's actually a fairly short presentation today, but there are a number of other supplemental presentations that I'll post as well. So renal. Renal is related to the kidney, and so renal is related to the nephron, and the glomerulus is a section of the nephron. And so really, when we're talking about renal issues, we're talking about the kidney. When we're talking about urologic issues, we're talking about the drainage system of the kidney. So a nephrologist deals with kidney function, a urologist deals with the drainage system and the anatomy. So if a kidney has to be removed, then obviously the urologist is the surgeon. So electrolytes. So sodium is a very common electrolyte found in the body. Usually the body does a really good job of keeping it in balance. Sometimes the sodium goes too high. It's actually not very common at all. We used to think, or a lot of us think, that if you get dehydrated, you'll become hypernatremic. You will, but the body tends to get rid of sodium in the urine, even if you're only putting out a little bit of urine. So you really have to be very profoundly dehydrated. So if you are hypernatremic, you'll be thirsty, you'll be weak, you'll be tachycardic, you'll be confused, and you'll have low urine output. Your reflexes will increase. Hyponatremia is actually relatively common. And interestingly, a lot of the same side effects occur, but usually the reflexes decrease rather than increase. Potassium is also very important. Potassium, we always think about as affecting the heart. So if you have too high potassium, you can get heart problems. If you have acidosis, such as diabetic ketoacidosis, it stops the potassium from going into the cells, and thus the serum potassium may go up, but overall, your body is not truly hyperkalemic. You're actually hypokalemic in the cells, and then you have a shift. So in that case, you usually give the person an intravenous with potassium in it. So hypokalemia is common. It's most common from diuretics. We give people medicines that make them pee out their potassium. Albuterol is another common cause of hypokalemia. And it can also affect the heart, but much less so than hyperkalemia. And those people, as noted, will have decreased reflexes as well. Nephrotic syndrome is when you have a lot of leakage of protein, not very common, and not really anything that we would treat with medications, although you can get it related to strep infection. You'd expect a lot of electrolyte imbalances and fluid imbalances and all sorts of things. So again, renal is filtering, it's the kidney itself. Urinary is the drainage system. When we're dealing with the drainage system, we can deal with urinary tract infections, and kidney stones are the two most common things that we deal with. Who gets urinary tract infections? Women do, because they have a shorter urethra. And the bugs that cause UTIs most commonly, things like E. coli, things that are normally found in the colon, just because it ain't that far from the colon exit to the urine entrance, or exit, I should say. So those are the most common. Most of those bugs tend to be gram-negative, so they're a little harder to treat. Cystitis is an inflammation of the bladder. So if you have an infection, you will get cystitis. Other things can cause it as well. And when you get cystitis, you have to go to the bathroom frequently. You suddenly have an urge to go when you have to go, and very frequently it will burn or cause pain when you have to urinate. If the infection moves up into the kidney, we call that pyelonephritis. It's a lot more severe. Often they need stronger antibiotics. We used to admit them all to the hospital, but usually we use strong oral antibiotics now, and we rarely need to admit them to the hospital. But they'll have a fever, they'll have flank pain, they may be peeing blood, or at least when we dip the urine, we can see that there's blood in it, which is microscopic hematuria. But they also often have diarrhea and vomiting as well. So how do we treat overactive bladder? Well, overactive bladder is treated with an anticholinergic. It's a medicine that would decrease that parasympathetic stimulation that causes stimulation of the bladder. We can also use a beta-3 agonist. That's actually incorrect on the slide. It's not a blocker, it's an agonist. It stimulates the beta-3 receptors and also does the same effect. Urinary stones. So the vast majority of kidney stones are calcium. There are medication implications. The treatment options, trial of passage includes 2 medications, which usually is an alpha blocker, which is theorized to relax the ureter as well as the sphincter. Pain meds, there's 2 pain meds that we use. One is fentanyl, which is a very short-acting narcotic in the emergency room. The other is Toradol, and Toradol actually has a very amazing effect, and patients with kidney stones often will get substantial, if not complete, relief. Toradol is an NSAID, decreases inflammation, but also seems to have substantially more pain relief effect than most other NSAIDs, especially in this particular instance. Renal failure is not usually medication treatment. There are treatments for blood pressure and other things, but there's not really a medication treatment for it. And here's your drugs of the week.